Hi everyone, Dr. Nightingale here, your clinical dementia specialist. I hope you're all having a great week. What I wanted to focus on in this video is something called ameliorating transitional shock. Now, you may say, what on earth is that? So many of us go through transitions in our life. We go through major changes, we go through minor changes. And when we are cognitively aware and cognitively intact, we kind of manage these transitions quite well. So when we think about moving house, divorce, the death of somebody, they're major transitions and they can have major impacts on our life. But we find ways of navigating those things and we find ways of dealing with them. We're able to problem solve. But when you think about having a cognitive issue, a memory issue that compounds a major change, then we have to deal with some underlying psychological and physiological issues, some malignant psychology and some malignant physiology. So how do we do that? Well, I work by using an individual transition management plan. And an individual transition management plan imagines that this transition, this change, is a movie. And the person who is living with a cognitive change, who is being impacted by that transition, is the star of the movie. They're the hero. And everybody who supports that change, the supporting cast, are the family members, the friends, the professionals. We're all there to support that transition and reduce the impact. And that's what the amelioration is. We reduce the impact of transitional shock. Transitional shock can lead to severe physical and psychological issues. So they can lead to falls, they can lead to heart attack, it can lead to cardiac arrest, they can lead to depression, they can lead to all kinds of mental health issues and all kinds of physiological stuff. So we want to reduce it, we want to ameliorate that. And we want to do that by putting the person in control, empowering them as much as possible. And one of the major changes, of course, and one of the major things that I deal with on a regular basis with patients and families is a transition from home into an assisted living, a memory care community, a nursing home, a care home, a group home, that kind of thing. That's a big major issue. And of course, people don't plan for that. It's not something they intend ever to do. None of us intend to do that. So we need to have an ITMP, an individual transition management plan. And I'm going to post one on this channel so you can see what it actually looks like. But here is one that I'm showing now. Is that clear, Lynn?
We can see it. I don't know if we can read it, but that's better.
Okay.
Okay.
You're going to be able to see this on the channel. We'll post that picture. Basically, what I'm looking for when we complete this form is we look at the type of diagnosis that the individual has. So our star is living with, for example, Alzheimer's disease. And it's got to a point in this scenario, in this case, it's got to a point where the person can no longer independently live at home. So a transition needs to be made into a care setting. Okay. So the first part of this is having an aim of the individual transition management plan. What is the aim of it? Well, the usual aim is to ensure a smooth transition. And we have to think about pre-transition, transition, and post-transition. All three. We have to think about those and we have to write a strategy for each one of those. Then we think about, okay, this change is going to occur on April the 1st. So for the next 12 months, what are we anticipating as some major physiological challenges? What are they? What are physical challenges that we might see over the next 12 months? And how do we prepare for that? How can we plan for that? So we might think about falls. There might be an increase in falls or risks of falls. So we want to do a risk assessment plan, and we want to put a strategy in place to reduce the risk of falls, trips, slips, hazards, those kind of things. And that becomes extremely important if somebody's moving into independent living, okay? Because on the whole, there's nobody there to support that person unless there's somebody additional going in there. And also the same question about the psychological changes. What might the psychological impact be of this transition? Let's think about them. And this will be based on the personality and the character of the individual. Some people might be really excited to go and do this, to move, to go and enjoy this transition. And other people may have fear, they may have trepidation, they may have resistance. So what are those challenges and how are we going to meet those? And then what about the sociological challenges? Sociological challenges being, is this person going to be able to integrate and engage with the community? What encouragement do we need to do that? What is it they want to do from a sociological point of view? What is their housing going to be like from a sociological point of view? Somebody might be moving from a 4,000 square foot house into a small independent living apartment or an assisted living community. Okay, so you've got to really think about that and how is that going to change and what is it going to be like. And then I have a golden rule whilst we're doing all this, and the golden rule asks these questions. Who will do what? To what degree of success? Okay, and this is it should be part of a shared action plan. So everybody involved in that transition should feed in to this ITMP. Think about this. When we live in the wider community, as we do, as I do right now, I am surrounded by something called an ecological inventory or inventory, depending on where you are in the world, how you use that word, that phrase. So we're surrounded by this ecological, these are environmental cues, like, how do I get to the school? Well, you leave your house, you turn right, and then you will see a mailbox. You turn left at that mailbox, and you come to a junction, and at that junction on your right hand side you see an animal rescue centre. You cross over that junction and come to some traffic lights. You then turn right at those traffic lights, those stop lights, and you continue going through 3 sets of traffic lights, 3 sets of stop lights, until you see on your right hand side a church. Opposite the church is the school. Now, by giving that description, I've used all those environmental cues. Imagine if I leave my house and all those environmental cues have gone away. They no longer exist. There is nothing to give me guidance. There is nothing to help me get from A to B to C to D. Okay? So really think about that when people are making a transition into a different environment. Think about how you can maintain some of those environmental cues or introduce new ones. Okay? And that is how we reduce people from having a malignant impact to a major transition. It's got to be thought out, it's got to be planned, and the individual has to be as involved as possible pre-transition, transition, and post-transition. By doing that, we have a smoother change, and people's well-being and people's happiness and joy is kind of maintained at a reasonable level. Okay, that's what I wanted to talk about there. Lynn, do you have any questions?
This plan that you put together, is it adaptable? Do you ever have to change it Are there circumstances when you just have to throw it all away and start over? You know, do you have to start over and
Yeah.
maybe you're halfway through when you go back to square one again?
It's a live document. It's a live document. So yes, you do change things around. And as part of the ITMP, you put together a transition checklist. So you look at the person's existing behavior, existing personality, existing character, and habits and routines, and you build a checklist around that. So throughout the observation period of the pre-transition, the transition and the post-transition, you're able to monitor any changes. You're able to pick up and identify whether there is stress, whether there is anxiety, whether there is increased fear, whether people are losing weight, whether people are crying, whether people are withdrawing into self, whether people become incontinent. So all those kind of things, we put together that checklist for that, and then you're able to monitor it and you change it as and when needed. Yeah.
So how many years have you been utilizing this tool, and what has your success rate been? And what are the pitfalls of using this plan?
Okay, so I did my PhD in ameliorating transitional shock in relation to people with dementia, learning disabilities and mental health issues and autism. So, and this was back in early 2000. So for a long time, but well before that, I was involved in transition. I worked in a hospital. There were two hospitals very close together, and I worked across both of them. And the government decided to introduce something called care in the community in 1992, which meant the hospitals had to close and all these patients had to be relocated into the community. And there was no thought into the relocation and transition of these people. It was, if Lynn and I had lived together on a ward for 30 years, and Lynn came from Liverpool, and I came from Manchester, and we have been friends for those 30 years, been close. It doesn't matter. Lynn is going back to Liverpool because at that time, under the Community Care Act in the UK, this is in the UK, Lynn was funded by Liverpool. So the funding sent her back to live somewhere in Liverpool in a group home or wherever it was. And my funding came from Manchester, so I was sent to Manchester in a group home. And there was no thought about what impact would that have on separating people, on demolishing friendships. There was a time scale for implementing the closures, and that's all that seemed to matter to the suits, you know, to the politicians. It was, this has to be done by this deadline. So these people go, move them, get them out. And we saw so many people dying of a sudden heart attack, jumping out of a window in the hospital, refusing to eat, developing incontinence, developing all kinds of diseases and illnesses that they never had in the first place. So that's what got my interest in that is so wrong. We have to do something about that. We have to change that. And within the hospital setting itself, the psychology department got together and decided to put together something about transitional shock. But of course it's too late because a number of these people have died. And so that's where my interest came. So you can imagine, you measured that against having a plan of action where we say to Lynn and Daniel, okay, you've known each other for 30 years, so would you like to live in the same home together? Yeah, because we're friends and we've been friends for a long time. So we would like that. We want to stay in the same place. So then we would make sure that could happen. So you just measure the two. The two of you're right. Lynn, get in the minibus, get in the car. A social worker is taking you to Liverpool, somewhere you've never been, you don't know. You came from Liverpool when you were 22 into this institution because a lot of the time then it was because if it was Lynn, because she was a female inebriant, as they called it, drinking alcohol as a woman, can't do that. or having children out of wedlock. You can't do that. So that's the kind of people that were moved into the hospital setting back in the day. And so they don't know Liverpool anymore, and I don't know Manchester anymore, but we're being sent to those places. So imagine the horrendous impact that has on an individual. So that's
Okay, but circling back to your practice with your individual patients and their families, because oftentimes you don't work with just the person that's living with a cognitive change. You're always, not always, but almost always working with their loved ones, their spouses usually, and or adult children. So in your experience as a practicing clinical dementia specialist, what has your success rate been using this type of plan, and what would you change to make it better?
I think over the years it changes, it develops, and we respond to changes out in the environment and changes in life and in technology and all those kind of things. So it's an ever-changing tool. It's not a static tool, but a lot of the strategy is the same, and it's successful, and the success comes from empowering the individual to make choices and to be part of that decision-making process, rather than me making the decision and
or
saying,
the doctor or the wife or husband.
Right, and saying, right, it's time. You're going to move into this place.
Yeah.
There has to be that period of transition. And of course, we're all trying to encourage people and support people to age in place. You know, that would be my choice. I would choose to age in place rather than move out of my home and go into somewhere else. That would be my choice. And that's most people's choice. But when it comes to a point where that isn't practical or possible, then we have to think about an individual transition management plan. And on the back of that, actually, even thinking about people receiving care at home and aging in place, there is still changes. And I'm dealing with something right now, actually, where caregivers have to go into a particular home, people's home, and they don't like it. They don't want them there. Because it's a change, isn't it? It's
they don't want the caregivers at their house.
Right, you're having people you don't know coming into your home and invading your privacy and those kinds of things. So there in itself is a need for a transition management plan. Okay.
Is it ever too late to, I know it's best to start the plan and plan it before the change happens, but what if you're in the midst of a change? Is it too late?
No, it isn't. And also I get the question of, well, what if it's an emergency, a crisis? Somebody has to be moved immediately from this environment to this environment. And we see that a lot in behavioural health. So if somebody goes into crisis and they have a psychotic episode, they have to go to behavioural health immediately. Even then, after that effect, there is chance and time to be able to adjust to that situation. Very often with behavioural health, it's for a short period of time while we assess medication and get them back on track, and then they go back again. But this back and forth can be a problem. Going into hospital is an issue. We know that people moving into hospital for even a short period of time, a couple of weeks, messes with their cognition and their mental health and their memory. So we have to be careful with that as well. But when it's a crisis and we can't avoid it, it just happens, then afterwards, because the person isn't really focused on those things, they're in psychosis. So dealing with the psychosis becomes a priority. And then working through that transition becomes secondary. But it's never too late. We can always introduce a checklist, a monitoring checklist. We can always do that.
So even if a person has a planned operation and they're going to be going from hospital to rehab before they come back home, you could implement that plan.
Absolutely. Yep.
For that reason too.
Yeah, yeah. That should be the case. There should be an ITMP in place for that.
And it doesn't have to be complicated, does it?
Oh, no, it's not complicated.
And it comes back to your true person-centered care. That's the
right
root of this entire thing. The reason why you created this is because
Absolutely.
You're focused on true person-centered
right.
care.
Absolutely, that's absolutely right, Lynn, and that's what it is, and that's what it's all about. And no, it doesn't have to be complicated. It just has to be based on the person's individuality, the person's character, their existing strengths, knowledge, competence, and then their needs. Let's focus on all the positive stuff and then think about needs.
So at the end of the day, it's about consideration, empowering the individual, and respecting the individual
Right.
and what's best for them, not what's convenient for their family or their loved ones or what makes sense for them, but again, true person-centered care.
Exactly. And we put the individual at the heart of everything we do. And again, I've had questions of, well, this person, they're so far along the journey of their dementia that they can't input. Yes, they can. They can always input. You might not be able to do it verbally, but you can be involved. That individual can be involved in a number of ways. You know, look at people's body language, look at whether they're withdrawing into self. You know, involve them, talk to them, ask them questions and say, you know, this we think is the right thing for you. What do you think? And you can judge people's body language. You can work through these things through body language. So it doesn't matter where they are on that journey. People can always demonstrate an opinion, a thought, a belief.
And what is the the cooperation that you get from the care homes or the memory care centers or other doctors or involving other professionals in this process? What's their willingness to be involved?
Well, everybody's different, but you need to have somebody who is coordinating it, who is assertive and who has a voice and who says, right, you need to be involved in this. You need to be involved in this because we want Alison to have the best, smoothest transition. And it's for everybody's benefit because, you know, we don't want to have to keep going to visit people because they're exhibiting unwanted behavior or they are physically getting sick. We don't want to have to deal with that. There's no need to deal with that. We can prevent it in the first place. So it's important that everybody who's involved in that individual's journey, and as everybody knows, I see the world of dementia being a journey, and there are so many people involved in that journey. So that's where collaboration comes in. It's important to collaborate. It's important to be involved with each other, and it's important that professionals involved know what each other's doing. So absolutely.
Because you all have a common goal.
Right.
And that's to
absolutely.
improve, increase, maintain the well-being of the person at the center of this journey.
Right, exactly. And it's kind of how you sell it as well, because, you know, if people are isolated at home and they are at risk of falling and then fracturing their hip and ending up in hospital and ending up never coming out again, we can prevent it. You know, people isolation at home, you move to an assisted living or memory care community or independent living, and there are so many people there and activities and things people can do and get involved with. And then we're reducing the risks of falls because of, you know, falls prevention clinics, falls prevention, risk prevention, all those
Physical
kind of things.
exercise,
Absolutely.
strengthening their bodies so they don't fall.
Making sure your diet and nutrition is good, because as we know, you know, one of the main reasons for admission into hospital is
Asphyxiation pneumonia.
Well, there is that, but dehydration, UTIs, which lead to infection, which leads to falls. Okay. So there's so many positive things when there's a transition, and those are the things we need to focus on.
How do we learn more about this?
You can learn more about this by contacting me at drdan@drdanielnightingale.com. That's my email address. Go to my website, you can contact us through that. Share this video. As I keep saying, every video, share it with everybody you know, because it's so important. Even if they're not involved in a journey of dementia right now, send it to people because they'll know somebody that is. So watch the YouTube channel, watch the whole thing. Don't just watch a couple of minutes, watch the whole thing. I should have said that right at the beginning because it's too late now. But, watch these videos and share them, and that is one of the best ways. And ask questions. Please engage with us. That's the thing we want you to do. We want you to engage with us. All the subscribers to the channel, there are lots of questions I'm sure you have. So ask the questions through Instagram, Facebook, or through the YouTube channel. Okay, anything else, Lynn?
No, I think that's about it.
Thank you very much for being here today. Thank you for watching, everyone. Have a great week. And remember, say it with me, dump the soda.